joined by Dr. Anna Volkmer, who's a speech and language therapy researcher at UCL. Everybody knows what UCL stands for, honestly, now. If they didn't at the start, they do now. And University College London Hospitals NHS Foundation Trust. I also have Natasha Clarke, who's a PhD student at St George's University of London. Hi, Natasha.
Hello.
And Dr. Lindsey Sinclair, who is a clinical research fellow at the University of Bristol. And you're also another one of those jobbing NHS proper doctors as well, right?
I am. I work clinically for the Avon and Wiltshire Mental Health Partnership.
Well, and we've talked about brain banks quite a few times today as well, and you work with the brain bank in Bristol as well, I believe.
I do. I'm very lucky. It's an amazing resource and a brilliant group of people to work with.
We've been encouraging people earlier today to consider donating to Brains for Dementia research, and Claire Durham was with us earlier explaining how they're taking pieces of the brain removed from people and using that live tissue, which is amazing. So I do need to take a quick comfort break. Anna, I'm going to ask you first of all, can you just tell us about your research? We've had quite a few people from FTD join us today, and I know that's something you look at as well. And somebody asked a PCA question, but I'm going to have to go away and find it. So tell us about your work.
Of course. Okay. So I am a speech and language therapist. I trained clinically, like Lindsey, but in speech and language therapy, probably about 20 years ago now. And I was working clinically with people with dementia and trying to deliver therapy for people with dementia. So many people ask me, what do speech therapists do for people with dementia? So the main things we do are we work in the area of communication, and we also assess people's swallowing. We assess people's swallowing to check that they're safe and not things aren't going down the wrong way and they're not at risk of chest infections. But what I was particularly interested in was communication, which is an area we also provide therapy in for people with dementia and their families. And often people say to me, well, not only what do people do, but kind of what's the point? But actually, what we know in speech therapy is that you can practice words, sentences, conversations in order to maintain speech and language and communication. So a lot of what we do is support people to do some practice, but also develop strategies to get around the kind of barriers and issues that arise when people have a communication difficulty related to dementia. And we work often, therefore, with the person around, or the people around the person with dementia. So often with their partners and family members. And that's where my research is sat, really. So I became particularly interested in this area clinically because there was very little research evidence about the effectiveness of this, or even the feasibility of doing this with people with PPA. Yet, well, I say PPA in a throwaway term. So what Adam was referring to earlier is that I am particularly interested in doing research working with people with language-led dementias, so where the communication difficulties are the kind of leading symptom, which is also known as primary progressive aphasia, so where progressive deterioration in aphasia, so language impairment, is the leading symptom, and these are related to the frontotemporal dementias. And what I did during my research is I've developed a communication partner training program for people with PPA, also with this type of language-led dementia, and their family members. And we've developed it with people themselves. And interesting, when Terry was speaking earlier, so 20 minutes ago or so, he was referring to the fact that a lot of dementia research hasn't always kind of worked with people with dementia alongside them. It's often kind of just the researchers and the clinicians have decided what to do and done it. But what we've tried to do in our research is actually combine forces with people to co-develop an intervention that meets people's needs. So that's the intervention that I've developed, and we're actually piloting it in Avon and Wiltshire NHS Trust. So we're piloting it across about 11 NHS sites with speech therapists delivering it in an NHS setting. And that's just coming to an end. Well, it's kind of in the last throes of collecting data at the minute, but we've collected quite a bit of data by speech therapy standards so far.
Thank you, Anna. I mean, you obviously you have so many fingers in so many pies that you've got so much going on. We could do an entire half an hour just with you. And in fact, if anybody is interested in knowing more about Anna's work, you have recorded multiple podcasts with us. But most recent one was only a couple of weeks ago, wasn't it, when you were talking to your colleague about your latest research? So please do check out our podcast. You'll find it on iTunes and Spotify, or you could even ask your smart home device to play the Dementia Researcher podcast, and you'll find it there. So look for Dementia Researcher and you'll find Anna there multiple times, and a blog this week as well. God, Anna's just so prolific, and she's got 12 kids as well, and she does clinical work and she researches. She's superwoman.
It's an occupational hazard. I just can't stop talking.
Which, although your research very nicely segues me into talking to Natasha. So looking at your work, Natasha, you're looking a slightly different look at speech to help with diagnosis. Tell us about it.
Yeah, so I'm really interested in language, as you say, from the perspective of spotting signs of Alzheimer's disease, which may sound a bit strange because people think of Alzheimer's as something that just affects memory, but actually we know that it affects people's language as well for some people very early on. And you've had a lot of guests today talking about biomarkers, so biological markers of disease. So we could do a brain scan or take a lumbar puncture or a blood sample and look for signs of Alzheimer's disease in the brain. With this research, instead of collecting a sample of blood from someone, the idea is to collect a sample of language, so a sample of their speech or their writing, and then we can analyse that and see if they are showing any signs of Alzheimer's disease. And that's really exciting because, for example, brain scans can be very expensive, lumbar punctures can be quite uncomfortable for patients, and even a blood sample requires that individual to notice a problem and actually go to their doctor and present the tests. But with language, we're producing more language than ever before. As you just mentioned, we're talking to our devices, our mobile phones every day. We're writing lots of emails. So it's a really vast sort of resource that we could potentially use to spot people with early signs that we can then look at prevention or offering them clinical trials to find disease-modifying treatments, things like that.
Fantastic. So, I mean, you say it's expensive to do that, but I imagine doing this with language sounds time consuming. Or do you have software you push that through and it's been trained to spot the differences? Or I'm reminded of that Moorfield's Eye Deep Blue study where they trained a computer to look at retinopathy eye scans to be able to spot problems there. Can you do the same with speech?
Yes, so that's the idea, that you can use computational methods. So you could use a computer that would take that sample of language and analyze it for you. So there are people, sort of linguists, who will do a more sort of human approach, but the research that I'm interested in, as you say, is training a machine to spot patterns in that sample that we wouldn't be able to spot as humans because there's too much data, and so it's an automatic process, and there's a lot of work into automatic speech recognition. So can you take that sample and directly sort of transcribe it as well? Yeah.
And how, two questions before I come to Lindsey. The first one is how reliable is this so far, and who would you take a sample from? Is this somebody who already thinks they might have a memory problem, or is this just somebody over a certain age?
So at the moment, we're still really in the research stage. It's more being used. It would probably be offered in the first stage, and I think it's already being done in some fields in clinical trials. So for screening, sort of a very low cost way to screen people, as opposed to someone who is in their own home. We're a long way away from that, but that is the general idea. So, and I know you've had people on earlier talking about, collecting different types of information. So it could be offered as part of a sort of flag raising system to then show who might need further tests. And in terms of how reliable it is, again, we're still at an early stage where we're collecting data, and there's a lot of work being done on particular data sets. And what we really need to do is branch out so we can look at other people who haven't been studied yet, because language can be very sort of personal. So we need to, we do need to sort of branch out and look at other data sets. But research shows that this could be very reliable. Yeah.
I mean, it's interesting, isn't it? Because our podcast I'm recording next week is also looking at gait, for example, as a way to differentiate. And it's quite interesting to see these different, what the public might perceive as quite unexpected things that are influenced by dementia, that then are able to support improving diagnosis, or then even potentially identifying treatment. Lindsey, I'm going to come to you next. So the thing you use is also just as interesting. So you've been looking at depression particularly.
Yes. So like Anna, I'm a practicing clinician, and I think what drove me into research was just my frustration with having people in front of me and not having all of the answers, and sometimes not even knowing what treatment to try first, or which one might work, and if that doesn't work, which one to go for next. So that's what drove me into research. And being an older adult psychiatrist, and I'm also qualified to treat younger adults, so people from the age of 18, I got really interested in how psychiatric symptoms change as people age. And it certainly seems that there are some psychiatric early symptoms in dementia. And particularly depression is quite a thorny problem, because it's something that we look for when we're in a memory clinic seeing someone with memory problems. Because if it's depression that's messed up their memory, we can treat that. And then they might not get a diagnosis of dementia, might not go down that pathway, got all those horrible memory treatments, that kind of thing. So it's well worth looking for. But equally, we know that some people who develop depression later in life, it's an early sign of Alzheimer's disease. So certainly studies have shown that in a year before someone gets a dementia diagnosis, there are a fairly hefty number of people who develop depression. And we don't know if it's people noticing that things are going wrong and their memory's less reliable, so that affecting their mood. We don't know if it's something biological in the brain that's causing all of that. So it's a really knotty problem, and we don't know if it's a risk factor or an early warning sign. So my research is starting to try and untangle that.
That's fascinating. And then does that leave you with the issue about whether, is it untreated depression? You know, if you can treat the depression early, might that have a knock-on effect to somebody who's going on to develop this, or is it just a biomarker?
I don't know, and the evidence base is really conflicting on this. So there's some suggestion that if you treat depression more aggressively, then it might reduce the conversion to dementia, but we just don't know.
And whether, I suppose, and how you treat that as well. We've already got a couple of questions actually, so let's go take the questions while we have them. Hector Perez asks, he finds this interesting: do you use semantic language classification like ontologies or any other tool of AI? I'm guessing this is for you, Natasha.
Yes, so my research is looking at all different features of language. So there's lots of different features in our speech. For example, the different words we use, so semantics, what do those words mean? We can also look at syntax, so how complicated our sentences are structured. We could look at the emotion of the word that we're using, and that has actually been found to be interesting in depression research as well. So yeah, so I look at all of those different features, including semantics, and I'm particularly interested in a kind of more novel way to look at semantics, which uses very large collections of words to kind of model what each word means, depending on the words that surround it. So depending on the words that appear around a word, that tells you what this word means. And we can sort of represent that the meaning of that word in a computational way. And that means that we could sort of summarize someone's speech, exactly what are they talking about, what are the semantics of that. We could summarize that in a number, basically. So that's sort of where I'm coming from.
Thank you very much, and thanks for the question, Hector. I hope that answers it. And Anna was nodding away there. So do you do the same thing, Anna, but you just do that in your head? You don't You don't have a computer?
Yeah, I do it in my head every time I meet a patient. No,
as a trained professional.
That's right, exactly. No, I mean, that is what we do, a lot of that. So when we meet a patient, often we do picture description tasks. I engage in conversation. I get them to name object pictures or verb pictures, or I ask them to follow single words, so we provide them with pictures and get them to select between semantic and phonological distractors. Also at a syntactic level, I would ask them to point to pictures, and I give them sentences and look at whether they're reversing sentence meanings or having problems with passive grammar, all of that kind of stuff. And it helps us build a picture. So for example, you know, a hallmark of a person with semantic variant PPA dementia would be that I would be looking for that person I will show them an object picture, ask them to name it, and they will say, I don't know what that is, you tell me. Or there's some kind of hallmark things you can tune into, or that people who have logopenic variant PPA, which also are kind of associated with an Alzheimer's pathology, will often make phonological errors in their output as they're describing things. And you listening out for that's really helpful. Or people with non-fluent variant will make agrammatic errors. So they often end up with lists in their speech. So yeah.
Could your model then be varied, Natasha, to not only to spot this, but to start to look for those different signs, like the FTD, the PCA, the things that we've been talking about, that you can distinguish between?
Absolutely, yeah. There's another really interesting project at St George's that's creating a mini linguistic state exam. So it's kind of a version of the more well-known mini mental state exam, so a language version, and that looks at all of those sorts of things that Anna's talking about. So you could, yes, and so you could then look at where people's difficulties lie and say classify them into particular subtypes of diseases. Yeah.
So Lindsey, I mean, just I'm not picking up on your work, but to thinking about the practical use of tools like this as a clinician working in a mental health trust, could you see this being something that would be easy to put, to do yourself?
I suppose one of the issues that we have in busy memory clinics is that it's very useful to be able to give people a precise diagnosis, but very hard to do, particularly when you've only got an hour and a half with the patient and their relatives, and they've got things which they want to get across, which are really important to them. We've got questions that we want to ask, which are important to us. We also need to check people over physically. So squishing all of that into a short period of time can be very, very challenging. So anything which could help refine our diagnoses in a kind of rapid, we could do it in a short clinic appointment kind of way, that would be really helpful.
Particularly if kind of done reliably as well to that accuracy level we're talking about. There is another question from Chris. Actually, there's a point here, first of all, from somebody called G. Martin Cooper, which I'm going to take, actually. He says, if Natasha spots early onset dementia, what then? If there's still no cure or even treatment, what early diagnosis is useless in this case? I'm going to pick back up on that, because I think if anybody who's been watching today would know anything, that one of the most valuable elements of early diagnosis is that there are treatments being worked on and lots of trials that are looking for people at various stages of the diseases with reliable diagnosis of certain kinds. And that early diagnosis may not give you a treatment right now, but it certainly will enable you to be placed into the right clinical trial or studies that could be useful to you. Plus as well, I think we know that there are, having a diagnosis of FTD or other things, what to expect in the future, and there are various other things that you can do to help depending on what that is. And knowing the diagnosis, knowing whether this is a dementia or not, is equally as important. That's why we've talked before about stroke, of making sure that this isn't just somebody having a stroke, or this isn't something else. I mean, that's comes up. It's come up quite a few times, hasn't it, Lindsey? I'm going to come back to you there. That argument for saying there's no treatment, what's the point, is one that's been played out quite a lot, hasn't it?
So what I generally tell my patients and their relatives is it's important to know to be able to plan. There are things that you can put into place. So I often talk to my patients when I first made a diagnosis about things like lasting power of attorney and having really clear conversations with their relatives about what they would want later on in their illness. Because if you do all of that really early on, when people are still very able to say, this is me, this is what I want, then it makes things an awful lot easier for the relatives later on, and also ensures that the individual gets the care which they would have wanted.
Absolutely. Okay, there are 3 quick questions which we're going to have to take because we're already out of time. That's mostly because I did all that prattling on at the start. So Chris says, hearing impairment came out as a larger than expected risk factor for dementia in the Lancet Commission, as hearing and speaking language are connected. Do you think linguistic biomarkers may be linked to hearing impairment findings? Ooh, Anna. Do you want expecting me to put that to you? Or you?
No, but this is probably Chris Hardy, because that's exactly the type of research he does. Yes, is the answer.
Tell him what he wants to hear.
Yeah.
Yes, it probably is. Thank you for your question, Chris. Elaine says there are studies looking at speech problems in BFTD. Or are there studies looking at speech problems in BFTD? I'm a carer and was not prepared for the dramatic loss of speech that occurred in her husband. But this is where your research, I know, looking at communication as this bigger thing, that there are other ways to communicate which aren't looking that beyond speech, aren't they? I know from doing podcasts last year in Sydney, that looking at communication as a whole beyond speech, that there are things you can learn to do, and you're getting better at understanding communication as a wider thing beyond speech.
You're addressing me, Adam?
Yes.
Yeah, I think, and just to flag, actually, I think more and more behavioural variant FTD and PCA, posterior cortical atrophy, we're realising that actually communication is often the second or third biggest issue with these rarer dementias. And even with the more typical Alzheimer's, more and more people are flagging problems with word finding and communication. So I think that across the board, across the dementias, people have language and communication difficulties, and people don't expect them at all. Often the carers in particular, it's quite a shock. It impacts on their relationships, and often we look at non-verbal communication, we look at alternative means of communication, so we can really support the interaction element. That's a lot of what I do, is focusing on interaction.
And do you know of any studies looking at speech problems?
Not off the top of my head.
But have a look on sign up to Join Dementia Research. I've said this various points throughout today. If there are studies looking for people, quite often one of the mechanisms they'll use to find people is through Join Dementia Research. So if you sign up there, register and give all your details, so you can see if you match to anything. And also reach out through FTD Talk, the website we looked at earlier. That will put you in contact with researchers at UCL that are working on FTD. And I'm sure if there's something more locally, or if you're not in the UK, they can signpost you to somebody else as well. Terry Blatter asks, fascinating speech and language. Academics use their hands with their speech. This may not be a platform of questions. Is it known as the Lease? Is it known how Lee Silverman can be accessed? Does that make sense to you?
Yeah.
Go on then.
Lee Silverman is a therapy that's been developed for people with Parkinson's disease, and we are using it for people with different types of rarer dementias that impact on speech. And we are seeing clinically, anecdotally, an impact more and more, particularly with the ones that, for example, the non-fluent variants. So yes, so it works on voice and speech.
This is wonderful. Thank you ever so much. Our next guests have arrived, so we're out of time.
Thanks,
Lindsey,
Adam.
I'm sorry,
Well
we didn't get
done.
to talk to you as much as I would have liked, but thank you very much to Dr. Anna Volkmer, Natasha Clarke, and Dr. Lindsey Sinclair for joining us. Keep up the good work. Well done. Thank you, Lindsey, for continuing to provide those services in the NHS, and you as well, Anna, keeping care going during COVID. You really are very grateful for that, and for taking the time to join me today. I know you must both be tired as well, coming to the end of your day. And Natasha, you're not tired at all, because you're just chilling at home, right?
Just writing.
No, I'm teasing, because aren't you writing up right now as well?
I am, yeah.
So thank you very much, all three of you, for taking time out of your busy days to come and talk to us. Thank you.
Thanks, Adam. Thank you.
Bye.
Bye.
Take care.